Hello, my name is Saba Saidi Rizi, and I will be presenting with Amira Hossein, Karan Sun, Belen Biro, and Klechi Kalu, and we will be critiquing the article about active conventional treatment and 3 different biological treatments in early rheumatoid arthritis. It's a phase 4 investigator initiated randomized observer blinded clinical trial.
Okay, so to give a little background about rheumatoid arthritis, not to get it confused with osteoarthritis, rheumatoid arthritis is an autoimmune disease that affects the joints. It is more seen commonly in women than men. Most average age is between 30 and 55 years old, but it is also seen in younger patients as well. Like most disease states, an early diagnosis and start of treatment does increase chances of remission and treatment success. For rheumatoid arthritis, the first line agent is methotrexate. This is a conventional DMARD, and you have other conventional DMARDs like Plaquenil and sulfasalazine. And when these conventional DMARDs don't work, you can use your biological DMARDs like infliximab and so on. Okay, so for the study design, setting, and research questions, the study design was a parallel investigator initiated randomized open label blind assessor multi-arm phase 4 study. There was 29 rheumatology departments in Sweden, Denmark, Norway, Finland, the Netherlands, and Iceland between 2012 and 2018, so a 6-year range. The research question was, is the treatment of rheumatoid arthritis with biological treatments, such as abatacept, tocilizumab, and certolizumab, is that known inferior to the treatment with conventional DMARDs like methotrexate or sulfasalazine? So this is a non-inferiority trial. And you can see the trial registration date. So for the population, those who were included in the study was basically 18-year-olds or older that had no treatment, symptom duration less than 24 years, moderate to severe disease activity with an activity score higher than 3.2, at least 2 swollen joints and at least 2 tender joints, and an RF factor, and both an RF factor and ACPA that were positive, or a CRP higher than 10 milligram per liter. And those who were excluded from the research were those that had previous treatment of their rheumatoid arthritis.
So there are a total of 903 participants and 812 randomized. The patients were randomized by 1:1 to 1:1 ratio, stratified by country, sex, and ACPS status. They were all given 25 milligram methotrexate on day 1 and weekly for 4 weeks, with 5 milligram folic acid supplementation every week. The patients were randomized into 4 arms. The first arm is they were taking conventional DMARDs, either oral propranolol, tapered from 20 to 5 milligram in 9 weeks, or enteric tablets, sulfasalazine, 2 grams per day, plus hydrochloroquine, 35 milligram per kilogram weekly, or 200 milligram daily, in addition to mandatory intraarticular injection of triamcinolone, hexatonide in all swollen joints at each visit. The second arm is the patient who are taking the certolizumab pegol 400 milligram on weeks 0 to 4, then 200 milligram every other week subcutaneously. The third arm was patient taking abatacept 125 milligram weekly subcutaneously. On the last arm, the fourth arm, was the patient who are taking tocilizumab 162 milligram weekly subcutaneously, or 1 milligram per kilogram IV every 4 weeks. The statistical analysis, it was a phase 4 trial in clinical setting and was non-inferiority analysis. The study was performed in 29 rheumatology departments in Sweden, Denmark, Norway, Finland, and Netherlands, and Iceland between 2012 to 2018, the study did not include public, which takes away from its external validity. The power analysis was 85 to 90% in a sample of 724 to 832. The primary analysis population was intention to treat, and it was a parallel study design. The treatment of variables. Our independent variable was the medication used, and the dependent variable was adjusted clinical disease activity index remission less than or equal to 2.8 at week 24, or the trial, which is calculated as patients swallow joints from week 0 to 28. And the tender joints also from week 0 to 28. Investigator global scores from 0 to 10, and patient's global score was from 0 to 10. The confounding variables were sex, ACPA value, country, age, BMI, number of swollen or tender joints.
Okay, so for the results, as Karen just mentioned, the outcome or the dependent variable was the CDAI remission rate, which is seen over here. It is 9.4 for abatacept, which shows that it has the highest remission rate, or it had the most efficacy in treating rheumatoid arthritis in the patients who were in that arm, which was higher than certolizumab as well as tocilizumab, and that was taken at week 24, which is the last week in that trial. Okay, so this was, as mentioned before, a non-inferiority analysis. So in this study, the analysis was that the CDAI remission rates showed that the conventional DMARDs used, which were hydrochloroquine as well as prednisolone, were non-inferior to certolizumab as well as tocilizumab, but abatacept would be considered superior, or it would be considered superior because it showed more of an effect. It had 9% better CDAI remission rates. So from this graph over here, we can see that all of them do show better marginal rates and do show better remission rates over time. But if we look at abatacept, which is the yellow line over here, it was slightly higher in that rate. Okay, and here is a forest plot, and this is one of the things that does give this study or this article more significance or quality. So this shows the non-inferiority analysis, and as we can see between the -15 and 0, the abatacept with methotrexate was in favor of the biological treatment more than the conventional treatment. It had the highest remission rate, as we can see, it is 56.3%. So one thing to also say about this is that for the results, as we can see, the confidence intervals, they all do cross 1 and 0, which shows that these results might not have been significant or statistically significant, but the results themselves show that still, from the data that we have, abatacept does show the highest remission rate and highest efficacy or highest effect in treating rheumatoid arthritis in these patients.
So some of the things that we used to critique this article was that the strength and the weakness. Few of the strength was that it had a good external validity because it included people or patients from several countries, like mentioned earlier. And then it also had intention to treat analysis, which prevents the attribution biases when evaluating the treatment assigned. A few other things that it was used was the power analysis, which was used to determine the sample size that was needed for the study. And then they used blinded assessors to reduce detection biases, which means the person that's assessing the results would not be, I guess, modifying or intentionally changing the results. So the other two things was that it included the forest plot, which was really helpful to evaluate the quality of the result. And then only two people or only two patients withdrew from the study after the randomization. A few of the weaknesses of this study was that it had an open label design, which can increase the expectation bias because both the doctor and the patient are aware of the treatment and they could be able to report their results or their effects according to that. It was such a short trial duration because it only had 24 weeks, which was not enough to check whether or not it had severe or any sort of adverse effects like the cardiovascular outcome. This study also lacked adequate concealment of allocation. And then lastly, it only had 10% of patients that didn't undergo randomization. So this could influence our results or outcome.
All right, in conclusion, the researchers in this study included that with abatacept or Orencia, there's a higher CDAI remission rates. And in this non-inferior analysis, it determined that conventional DMARDs were non-inferior to certolizumab or tocilizumab, but not abatacept. Abatacept had the lowest withdrawal rates and adverse events rates, better results in treatment in naive patients. The efficacy and safety of active conventional treatment based on the methotrexate combination with corticosteroids with nominally improved results for abatacept. So there are also some limitations in this study. The study included it needs more ethnicities because most of the countries they included are majority white. Also, the study was an open label design, which it could basically impact the choice to continue beyond randomization, and that could include more bias. We thank you so much for listening to our critique and have a wonderful day.